Over to you, sir.
Good
Okay,
afternoon,
sir.
everyone. It's a great pleasure to have you all here. I'm Dr. Omkaro, working as a medical advisor at Hetero Healthcare. Our topic of discussion for today is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding of the postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since 25 years. It has more than 300 products in its portfolio and has an employee size of 21,000 globally. It is also among the largest manufacturers of ARVs, APIs, and FDF in the world. It also has 36 state of the art manufacturing facilities and has its presence in more than 126 countries. It also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. Now, I would also like to introduce Dr. Kavya Patel ma'am, who will be the speaker for today's meeting. Dr. Kavya Patel ma'am is currently working as a chief obstetrician and gynecologist at Marulia Hospital. She has also worked 3 years at Anand Hospital in Navsari as assistant gynecologist. Ma'am has done fellowship in laparoscopic surgery and advanced OBGY sonography. So with this, I welcome you, ma'am, and hand over the session to you. Over to you, ma'am.
Okay. Hello, good afternoon, all. Myself, Dr. Kavya Patel, and today I'll brief you about overview of postpartum hemorrhage. So, first of all, postpartum hemorrhage, a daunting event. PPH is lost at least 500 ml of blood following vaginal delivery and 1000 ml following cesarean section. As you can see in the diagram, normal postpartum patient with contracted uterus preventing the hemorrhage, and in the uterine atony allows the hemorrhage to flow into the uterus. PPH is common and can occur even in women who are not at risk. PPH is leading cause of maternal mortality in low income countries and primary cause of nearly one quarter of all maternal deaths globally. Postpartum hemorrhage, it's unfortunate yet common. Leading cause of maternal mortality, according for about 35% of all maternal deaths. MMR in developing countries was 240 per 1 lakh live birth compared to 16 in developed countries. Maternal mortality ratio MMR is 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. Around 38% of maternal deaths are due to PPH, 25.7% of global deaths take a place in India, and two-thirds of this attribute to PPH. India is an expectedly high maternal death rate, 540 per 1 lakh live birth. Etiology of PPH, it's a four common cause like tone, trauma, tissue, and thrombin. Tone means uterine atony, inability of uterus to contract, which may lead to continuous bleeding. Thrombin means coagulopathies, failure in clothing, and trauma, uterine trauma, injury to birth canal, rupture, and uterine inversion, laceration. Tissue means retention of placenta, clots, and abnormal placenta. Clinical findings in PPH. Clinical findings in PPH like a degree of a shock, combined with blood loss like 500 to 100 ml is around 10 to 15%. Blood pressure changes not significantly. Symptoms and signs palpitation, dizziness, and tachycardia. In degree of shock, if mild, then blood loss will be 1 liter to 1500 ml, around 15 to 25%. Blood pressure will slightly fall, and symptoms and signs will be the weakness, sweating, tachycardia, and in moderate 1.5 to 2 liter blood loss, and marked fall in blood pressure, restlessness, pallor, and oliguria seen. In severe PPH, 2000 to 3000 ml blood loss, 35 to 45% around, and profound fall in blood pressure, collapse, air hunger, and anuria you may be seen. Diagnosing in postpartum hemorrhage, rapid assessment of patient status presence of tachycardia and hypertension, assessment of vital signs and blood loss, assessment of entire genital tract for the lacerations, hematomas, and signs of uterine rupture, manual examination for retained placenta tissue, assessment with bedside ultrasound to check if the uterus is non contracted, evaluation of uterus to check for the uterine inversion, complete blood count to check the hemoglobin, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. As you can find in poor uterine tone, clinical findings abdominal palpitation, uterus feels relaxed, boggy, and soft. Uterine fundus may be the felt above the umbilicus if uterine cavity is filled with the blood and clots. Investigation you need to investigate the full blood count, coagulation profile, urea, and the electrolytes. If patient is not responsive to fluid and blood replacement, abdominal ultrasound needed to exclude the uterine rupture or the intraperitoneal bleeding. Management is uterotonic agents like the oxytocics, prostaglandins, and ergot alkaloids. Uterine balloon tamponade like hemostasis algorithm. See the main article for the recommended stepwise. Surgical measures are also used to complete and treat the PPH. If tears and trauma, clinical findings from areas of trauma within the genital tract, uterine rupture, extension of the uterine angles, tears during the cesarean section, extragenital causes such as the subcapsular live rupture or the rupture of the ovarian or the splenic vessels. Investigation as the inspection during the cesarean section and the ultrasound to identify the free fluid in the uterine rupture. A management like the repair of the identified genital tract trauma, pelvic arterial embolization, you may done in retained tissue identified during the bimanual examination, investigation, examination under the anesthesia, manual removal of placenta, retained product of conception under the regional and general anesthetic. Coagulopathy, like continuous bleeding, contracted uterus, then you have to identify and investigate the urea and electrolytes, full blood count, coagulation profile, management. You have to manage the immediate replacement of the blood and coagulation factors and platelet. Surgically, only with the trauma or atonic hemorrhage, unresponsive to the medical treatment. You have to do a surgical treatment in a rationale for the development of carbetocin in new heat stable formulation. Carbetocin is available in a room temperature stable formulation and convenient while presentation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid the degradation. A heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between the 2 to 8 degrees Celsius. Resource: poor countries do not always have cold chain transport and storage capability. Is a stable This carbetocin is stable at a room temperature. Half life is 24 months at 30 degree and 75% humidity. Avoids the needs for the cold chain storage and logistics. It's provided in a vial. Use of a uterotonic agent is at the crowning of a baby head, at the delivery of a anterior shoulder, at the end of the second stage of labor, and the following delivery of placenta. Prophylactic use can be used in the prevention of PPH, active management of third stage of labor, therapeutic use, management of PPH, and molecules that are used in the uterotonic agents like the oxytocin, carbetocin, ergometrin, symptometrin. It's a combined is a 500 microgram ergometrin and plus 5 international unit oxytocin and misoprostol. You can see the carbetocin, a next generation drug for the PPH management. It has a prolonged half life and a reduced enzymatic degradation and was created by making a several modification to the oxytocin structure. As a carbetocin clinical evidence, efficacy and safety versus carbetocin and oxytocin, you can see the brief description. A synthetic cyclic peptide of the naturally occurring posterior pituitary hormone, and it binds to the oxytocin receptor in the uterine myometrium, stimulating the contraction of the uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Long acting synthetic analog of oxytocin with agonist properties, carbetocin is binds to the oxytocin receptor in the uterine smooth muscle and resulting in the rhythmic contraction, increase frequency and exist in the contraction and the increase uterine tone. As pharmacokinetics of both drug in the oxytocin, it's almost immediate action with peak contraction after 30 minutes and intramuscular slower action and taking 3 to 7 minutes but produce the longer lasting effect for the 60 minutes. Its half life is 1 to 6 minutes as compared to the oxytocin. Carbetocin is sustained uterine contraction within the 2 minutes and lasting for 6 minutes, followed by rhythmic contraction for 60 minutes as double to the oxytocin. And intramuscular, it's a contraction lasting for about 11 minutes and rhythmic contraction for the 120 minutes, and its half life is 40 minutes. So storage is its storage condition is up to 30 degrees Celsius, and in oxytocin you have to put it in a 2 to 8 degree Celsius to preserve its activity. As clinical indication, oxytocin can be used in the induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH. As carbetocin is not used in all these, only for prevention of PPH. Carbetocin non-inferior to the oxytocin, WHO champion trial. Uh, you can see this greater than 1000 ml blood loss. It's a very good drug to use for prevention of the PPH and frequency of the blood loss. At least 500 ml of the use additional uterotonic agent with the carbetocin was proven to be a non-inferior versus oxytocin. The use of the additional uterotonic agents interventions to stop the bleeding and adverse effect did not differ the significantly between the two groups. As you can say, the Cochrane's review for women who undergo cesarean section, carbetocin resulted in the satisfactorily significant reduction in the need of for the therapeutic uterotonics compared to the oxytocin. Also, carbetocin is associated with the less blood loss compared to sinometrin in the prevention of PPH for the women who have a vaginal deliveries and associated with significantly fewer adverse side effects. As guidelines for recommendation, Society of Obstetrician and Gynecologists of Canada, you can see the different countries. WHO in 2020, 2018, one of the following drug, carbetocin, is most commonly used for the PPH prophylaxis. SOGS Canada has also approved the carbetocin, and the New Zealand, FIGO, Germany, Austria, Swiss body, FCOG France, they all accept the carbetocin for the prevention of the PPH and to decrease the blood loss after the delivery. Okay. Or I don't have any case study, but since so many years I'm using the carbetocin, and I guess I did not use any surgical intervention for the PPH management. I actually using in daily basis, and I'm routinely using the carbetocin in every patient for the prophylaxis of PPH management. Thank you.
Thank you so much, ma'am, for sharing your valuable insights. It was such a wonderful session. Now we move forward to the next part of our session, that is panel discussion, where we'll be having frequently asked questions and real world scenarios. So,
Okay.
moving to the first question. So, ma'am, considering the use of carbetocin as a first line drug to prevent postpartum hemorrhage, what are the specific advantages or benefit does it offer, considering its use as a first line agent?
Okay. It's better because it's a heat stable drug, and in many countries, there is a no. It's like power and no facilities for that, so you can use it at every condition. So it is a first line drug. I think you should use as a first line drug in every condition, so you can prevent the pph. So many cases are there in our country, so we have to use the first line drug, as this pph can be controlled and mortality can be reduced.
Okay, okay. Thank you, ma'am. Moving to the next question. So, which are the patient profile, ma'am, in which postpartum hemorrhage can be anticipated?
Okay. There are so many conditions like the polyhydramnios, twins pregnancy, triplets pregnancy in previous history of PPH, and if prolonged induction of labor, you can use the this drug as a prevention of the PPH and anticipate the PPH condition.
Okay, okay. Means we can say that if PPH is anticipated in the conditions that you have mentioned, carbetocin can be started and can be used
Yes,
as a first line.
yes. Ah,
Okay,
yes.
okay. Moving to the next question, ma'am. So, doctors generally use oxytocin for labor induction. So,
Hmm.
in such scenario, in the same patient, can then after carbetocin be used for prevention of PPH?
Yes, you can use. No issue. Oxytocin is used for the in many condition, induction of labor, augmentation of labor, but carbetocin can be used in only prevention of PPH. But if you are using oxytocin for induction of labor, you can absolutely and safely use the carbetocin after the delivery for prevention of PPH. There is no harm and no issue.
Okay, okay. Thank you, ma'am. Then, considering, ma'am, the route of administration, so as IV route is the preferred one, so if we modify the question a bit, are there any scenarios or special cases in which IM route would be preferred over IV route?
Okay, if any, you may predict for the PPH. If I have mentioned all that condition like polyhydramnios, triplets, twin pregnancy, previous history of PPH, then you may predict the PPH can occur in this patient. So actually, you can use the IV route, and if the patient is non-risk, then if any no risk is available, then you can use the intramuscular, so we can prevent the pph. If occur, then we can manage. So intravenous route is in my condition, I guess. If you are predicting that this patient will go in pph, so give the iv route, and if the patient is non high risk, then you can give the intramuscular.
Okay, okay. Means in patients who do not have the high risk, we can go for
Yes.
IM route. Okay.
Yes.
Moving to the next question, ma'am. Considering its safety and tolerability in patients, so what is observed in real world? How well it is tolerated?
It is excellently tolerable drug and no issue till actually I am using the drug since 2 to 3 years, but there is a no side effect and a very good tolerability, and a little bit nausea and vomiting and headache. Otherwise, less than 1 to 2% in patient had complained about that. Otherwise no issue at all, and this drug is acceptance is very good.
Okay, okay. Means we can say that the side effects which are observed are of
Uh,
minor severity and in very less
yes,
number of patients.
yes, yes.
Okay. Moving to the next question, ma'am. So, if patient is not responding adequately with carbetocin, then order of preference, which additional uterotonics would you use?
Mostly, personally, I feel, frankly speaking, I have used carbetocin in every patient, and if it not work, then otherwise, I don't think so. It will not work. Otherwise, I will use in carboprost or extra massage, uterine massage, or you can use the and other any medical management. But otherwise, in 2 to 3 years, I have not seen any patients with severe pph. Then I have to move on the surgical method. Generally, it can be managed by this drug, so I don't think so कि उसके ऊपर भी
Need for
कोई
other agent is
हाँ
there.
yes, it is
Okay, okay.
enough. I guess.
Okay. Okay. Moving to the next question, ma'am. You have already described about this question. So, and you have spoken on this, but any additional comments that are considering the advantages of carbetocin over other uterotonics?
I have mentioned already in the lecture that it is a heat stable drug, and its shelf long half life is very long, and it can be used in the lower poor country also. It can easily available, and we can store it on a normal temperature, highest humidity. So it is a base drug in compared to the oxytocin. It's a heat. You can store at 2 to 8 degrees Celsius, and its carbetocin effect is very good. It's commonly it act on the smooth muscles of the uterus, and rhythmically contracted for long lasting for at least 60 minutes around. So it is a base drug in compared to the other uterotonics. So I guess so many countries have also approved this drug for the first line treatment as a PPH prophylaxis. So it is a, I guess, a better drug for in comparison to all uterotonics.
Correct, correct. Okay, okay, ma'am. Moving to the next question. So, should carbetocin be kept as a reserve drug or it should be used as a first line?
I guess it's used as a first line drug. It is a base drug, so you can first why to waste a time for to take happen PPH. So better to take a first drug and prevent the PPH as much as possible, and we can manage and prevent the maternal mortality also by
Okay,
that.
yes, yes. Moving to the next question, ma'am. So, if you have to summarize and conclude, considering your experience of carbetocin, its safety and efficacy, any comments that you would like to know to the delegates, mention to the delegates?
Okay. Actually, it can be used and safe in every RH negative mother or every patient, and you can easily use in every high risk patient also. So, I guess I feel like you may use this drug in every patient for the prophylaxis and the prevention of PPH. As many condition I have suggest in previous condition like. High risk pregnancy, all IVF pregnancy, induction of labor for the long induction of labor, and polyhydramnios, triplets, twins. When in this condition, when you predict that this patient may go in PPH, so you just use this drug. Don't wait for a PPH. Just use this drug before the PPH happen, and we can manage and less the complication will develop the maternal mortality decrease, and our mortality maternal mortality will be decreased, so condition will improve, and bleeding loss will be less happen chance. That why we have to use this drug routine base.
Okay, okay, okay. Thank you so much, ma'am. So this brings us to our end of our session. So thank you so much for sharing your valuable insights and guiding all the delegates regarding efficacy and safety of carbidocin, where it can be used and why it can be used as a first line agent. So
Okay.
thank you. I would also like to thank all the delegates for their active participation into the meeting. So thank you once again, ma'am. And this marks the end of our meeting. We can close the meeting now.
Okay, thank you.
Madam, thank you so very much once again from Royal Care. Thank you for
Okay.
accepting our invitation, madam, for conducting this experience sharing program.
Okay, thank you.
Ma'am.